Welcome, and we're going to stand for the Pledge of Allegiance, and we'll get started. I pledge allegiance to the flag of the United States of America and to the republic for which it stands, one nation, under God, indivisible, with liberty and justice for all. Good morning and welcome. Just a quick announcement. The much of the Senate and Senate staff need to be at a funeral service at 11 a.m. So we are going to limit testimony today to 3 minutes. Sophie will be keeping track of that as well as she does, and we'll just please be mindful of that. So with that, I'm going to open the hearing on Senate Bill 252 relative to criteria for providing certain medical care through telemedicine. I'll ask the prime sponsor to introduce the bill.
Good morning, Senator Rochefort, Chair Rochefort, and members of Senate Health and Human Services. Before I get started, is it okay if I have Dr. Ballard join me?
Absolutely,
Chair
yes.
of the Telehealth Commission, because we're doing this together.
All right.
Okay, so for the, again, good morning, and for the record, my name is Sue Prentice. I'm the state senator from District 5, representing 15 communities in the wonderful Upper Valley, large part of Grafton County, a few in Sullivan County, and one in lovely Merrimack County, the town of New London. So I'm bringing this bill at the request as well as through discussions with representatives from our telehealth commission in order to build access to healthcare through telehealth, through telemedicine for our population that are in state and county jails. What we're finding, and it's great to have Dr. Ballard with me because he can actually present the global data on this, but my concern is that we have inmates, again, it's usually going to be the longer term are going to be in the state prisons, but we do have some folks in county prison that they have care while they're in there, but when they leave, they don't have an established care mechanism. And what we know is that when people have access to health care, that they're able to address their health care needs, take care of themselves, get back to work and lead productive, prosperous lives. Now, we know this is a high utilization population that's incarcerated. There are substance use disorder issues. There are mental health issues, as well as there's a number of medical conditions that they either, came in with or developed while they were in there. Recently, in working with Dr. Ballard, we were reviewing and talking about a case of somebody who had, multiple serious, cardiovascular issues and was, as well as mental health and substance abuse, and was incarcerated. And I'm thinking about that person coming out of the setting that they're in and not having an established relationship. So the purpose of this bill, and I'm going to talk about some of the moving parts because you're going to hear from some folks behind us that want to have some really good suggestions about amendments that we should consider. But the purpose here is to establish that relationship while they are incarcerated so that when they come out of being incarcerated, they have that point of contact with a primary care provider in order to continue their health care and move them either off to the specialty care that they need or just be that one medical home for them that is so important. They don't have it while they're incarcerated. Again, we're looking to build that continuum out. I think over time that this will save costs for the overall healthcare system because I'll leave it at this and then talk about some of the potential amendments that could be made. One of the things we know is that when people don't have health care, Dr. Ballard and I have both worked in emergency departments. If they don't have access to health care, where do they go? They come to the emergency department, and the emergency department, and granted, they may have an emergency which could have been prevented if they had regular health care, but the costs are different. The costs are higher. The costs to our system are higher. So we can actually drive those down. And we've seen this actually with the Granted Advantage by providing, just using the example of Medicaid coverage, that we've seen a drop in the number of users for, in the emergency department, as well as associated costs, because they now have a medical home that they can go to. Before I turn this over to Dr. Ballard to talk about some of the findings, because for all the time that we've been talking about telehealth, there's been a commission that's been established and has been working through this. So we have some findings that are directly relative to this proposal today. I want to bring to your attention that I've heard from the nurse practitioners and who serves a role in providing primary care, that they would like to be a part of this effort as well. And although I haven't heard from them, I do think it makes sense to talk to the physician's assistants because many of them play a role in primary care practices. So in talking with the nurse practitioners, I thought I should have a chat with the PAs as well. And then lastly, I am, as I put together with these stakeholders, this final language, which we can do pretty quickly, I'm going to look to eliminate the section or item number 2 from line 12 down to 17, where we talk about telemedicine in terms of eye care, because they are an exception to this. You really have to have that physical exam in order for eye care to have a prescription for whatever, for your glasses or for medication. There's a difference there, and we've seen that. So we have great partners with the eye doctors in the state, but that's going to be a smart thing to do, is to actually remove them from this. So I'm happy to take any questions you might have, and my co-partner here, Dr. Ballard, has some opening comments as well and is a great resource for questions and answers.
Great. Are there any
Actually, answers
questions
to
from
questions.
the committee?
I have some, Mr. Chair, but I'll wait till after Dr. Ballard says his opening statement.
Okay, great. Sounds good. Dr. Ballard.
Good morning, Mr. Chairman, Senators, and members of the committee. My name is Jonathan Ballard. I work as the Chief Medical Officer of the New Hampshire Department of Health and Human Services, and I'm here to provide information, but also served in a role as chair of the Legislative Commission to Studies Telehealth Services over this past year. And so we have the final report available to you in written copy, and there are a number of findings from that commission. Obviously, during COVID-19 pandemic, there were great flexibilities provided to providers to perform services through telehealth. And there were flexibilities that were made from the federal government that have been still extended to this day to allow the prescription of controlled medications and their overall practice of telehealth to be performed. At this point in time, the federal requirements are stricter than the state requirements. So the Drug Enforcement Agency and the Federal Department of Health and Human Services allow for this practice to happen of prescribing controlled medications as part of the overall health care performed through telehealth.
I think
But
you
the
meant the state is stricter than the federal.
state is
Yes,
more
I just
stricter.
want to make sure that
Yeah,
yes, the state is stricter as
state
today.
is stricter than the federal. So the Telehealth Commission heard from a number of representatives, providers, patients who receive the service. We heard from, though, a lot of providers, particularly psychiatrists, pediatricians, other providers who provide telehealth services, including those that provide medication-assisted treatment for treatment of substance use disorders. And we heard a lot of complaints about New Hampshire law being stricter. We heard that this New Hampshire law had a lot of red tape, and they showed evidence that the practice is safe, effective for many conditions, and we're asking for this change to be done in the law. And so you'll see on the final report, there's a lot of data that shows how telehealth really took off during the pandemic and is still maintaining a sizable level to maintain access in rural areas and individuals that are homebound and or just needing to remain at work and can quickly do a telehealth visit. And so the final report, I believe it's on the last page of that says final recommendations. The committee really only had one final recommendation, And it was the recommendation of this commission to amend current New Hampshire statutes that prohibit the prescribing of controlled medications via telehealth without the need for an in-person visit, and to align state statutes with applicable federal laws and regulations. That was really the only finding other than to continue studying telehealth. And that was a unanimous vote by the commission. I'm happy to leave it at that and take any questions.
Great. Thank you. Senator, did you have something else you wanted to add?
If I may, before, I know Senator Birdsall has questions. I want to, what I want to share is that I was involved in, I worked with Senator Birdsall and Senator Bradley on HB 500, as well as another Senate bill where we paid particular attention to this patient-provider relationship and the in-person nature of that. I have not forgotten about that at all, but I thought it was important to open the door and talk about all the things that this commission has brought forward, and then see if there's a place that we can jointly come to. So that remains important to me. I know it was important at the time that we passed this and was key to it, but we have some data now, or some evidence. We have some data from this commission that I think has given us a look into the practice that is worthwhile in talking about. So I just wanted to be clear with the committee that I'm completely respectful of the work that we've done on this in the past. I just wanted to open that door and let's see where we get. Okay, thank you.
Thank you. Senator Birdsall.
Okay, thank you, Mr. Chairman. Thank you for taking my question. The only concern I have, I don't have a problem with telemedicine at all. I think it's a really good program that we've got. But taking out the after establishing a physician-patient relationship with the patient, part of me says, what are the shouldn't the physician or the physician's assistant have at least had whether it's a telemedicine or an interview with them before they start seeing this telemedicine doctor that prescribes specific, not so much non-opioid, but opioid. I just feel like that one-on-one, whether it's telemedicine or not, needs to happen.
Senator Birdsall, that's a wonderful question. I had the exact same question, and I asked many of the providers about that. So on the non-opioid side, we heard a lot from psychiatrists, treatment providers of substance use disorder, that when that window opens for an individual, that the access and ease of engaging in especially a cognitive-based service that doesn't really, a physical exam doesn't aid in your diagnosis, that is a really good tool for engaging patients, and they showed outcomes that were as effective and safe. On the opioid side, we heard from hospice providers that they, especially for patients in rural areas, that it was very difficult for them to prescribe what is necessary for patients to relieve suffering. The current statute does have that line that they still have to follow standards of care, and it would absolutely be not part of standard of care to prescribe an opioid through telemedicine. That would be reportable to the Board of Medicine and still be covered under the statute as something that would be reportable and outside of the practice and standard of care.
So are you saying, follow
Oh,
up?
yeah, absolutely.
Sorry. Are you saying that typically when this happens, it happens in hospice versus, yep.
The provider that came forward to the telehealth commission spoke about how they couldn't leave their practice to go to treat their homebound patient. It was an elderly person who was on small amounts of opioids. Mm-hmm. It was so cumbersome for that older person to come in. Physically, it was painful for them to do so. The practitioner couldn't leave their office, and so that was why they wanted that flexibility to prescribe a small amount of pain medication for that individual that they had seen, or that their partner had never seen before and needed to cover for them. And that's why they wanted it to not have that first initial visit, because as the statute is now, just because your partner saw them previously and you have all their medical records, you're prohibited from doing so.
Absolutely.
And I'm not saying that the one-on-one relationship can happen via telemedicine, but at least that first consultation, so that there is a patient relationship, whether it's telemedicine or in person. Don't you think that they should have at least, instead of coming in from the cold and having an opioid, at least have the first, whether it's telemedicine or in person, having the first conversation, finding out what's going on before you authorize the opioid?
Exactly. That would be the practice. I would believe this is the standard of medicine, is to anytime you're prescribing an opioid, outside of those scenarios where a patient's either in hospice or has chronic pain and your partner has seen them. I think that's why that language is in there still, the opioid and non-opioid both allowed. If you were really wanting to go after, if you wanted to eliminate the opioid prescribing through telehealth without that follow-up in-person visit, you could strike that opioid and non-opioid and just leave it non-opioid controlled medication in the language. Simply providing, not my opinion, but just informational only.
Senator Long.
Thank you, Mr. Chairman. Can you define for me a small amount? You mentioned a small amount. Is that 5 or 10 or?
Well, in the one patient scenario, it was a small, low-level prescription for a controlled medication. It wasn't a high amount. I don't remember the exact dosage, but they described it as a small prescription. And I could see that that would be a reasonable practice in the practice of medicine, that if your partner was already prescribing a controlled medication, or you were, and you were going on vacation, and your partner, and then that person contacted your office requesting a refill, and you said, no, I need to evaluate you through telemedicine first, I could see that as a reasonable practice of medicine.
Okay, so the amount was the dose and not the quantity.
I think in this area it was both. It was a
both.
small dose and a small quantity.
All right, thank you.
Any other questions? I just had a couple things. I know I spoke to the prime sponsor about this, and you and I talked yesterday about the Hate Ryan Act of 2008. And just to clarify for the record that the Hate Ryan Act dealt with telemedicine and federal law and all the nuances around that. In 2020, a lot of that was relaxed. And I was privy to that because I was on the Board of Pharmacy at that point. We had these exact discussions at the Board of Pharmacy, whether it be psychiatry or incarcerated individuals. And the goal was to get people the medicine they needed. And now, obviously the pandemic is gone, but we do have people incarcerated. And, as the prime sponsor pointed out, that, having access to that really has been shown to be critical and key to keeping them off, to keep them on the right track. So just for the record, if you could explain the Hate Ryan Act, not necessarily the Hate Ryan Act, but the temporary rules and how this relates to the temporary rules and how it aligns with that.
Senator Rochefort, very good topic to make sure it's on the record. So in 2020, when there was an initial federal relaxation of that act, which says that in order to prescribe a controlled medication, you did have to have an in-person visit. It allowed the telemedicine flexibility. That was extended once, and then it was extended twice. And then we received notice that there was a desire by federal HHS and the Drug Enforcement Agency that they were trying to put some rules around this practice. And they're while balancing the access that individuals were having, because it is now a standard practice of care across many parts of the country to provide psychiatric care, anxiety medications, other types of medications that are still in that controlled category. And so they didn't want to cut off the access that individuals were having. So they ended up in December extending that flexibility in the federal registrar, so in rules, again in December, and it goes through December of 2025. Now, at any time between now and the end of 2025, the DEA and the federal HHS may publish new rules that have those new guardrails around it. But as of right now, New Hampshire statutes is it's prohibitive, so it's stricter than the federal. Now, at any point where if the federal became stricter than New Hampshire, then New Hampshire practitioners have to follow the federal stricter guidance. And the same thing if they extend it again, New Hampshire providers would have to follow that. But right now, since state statutes are stricter than the federal, they have to follow the stricter state statute.
Great. Thank you.
And then may I just comment on the part about the incarcerated individuals? So you may be aware that in New Hampshire, we have a mandatory community reentry benefit for Medicaid that federal DHHS CMS required for New Hampshire for children. And New Hampshire also received a waiver to allow Medicaid beginning 30 or 45 days before a person is released from prison or jail. And so what that allows for is individuals then to establish relationships with providers after they leave to try to reduce recidivism. And so it's obviously very expensive for a state and difficult in transporting inmates or prisoners to those types of providers that do that type of care. And so if this is the allowable, it would allow that care to start pre-release and then create appointments post-release, and it would save the cost on transportation.
Great. Thank you. Senator Abar, do you have a question?
Just real, yeah, sorry for walking in a little bit late, but does this proportionally affect those that are in hospice more than most, or the restrictive rules?
This is the law in New Hampshire for all providers. So if an individual was needing a controlled medication, they could only do a telemedicine visit. They could not be prescribed it. So this if you were to enact this bill as written, then that hospice, then they could do so.
Thank you.
Right, great. Thank you. Any other questions? Thank you very much. Jim Monahan.
I have to pass a bill to make the federal law listen to us.
Yeah.
Out of control. I think that helps you.
It's a reflection of me.
Good morning, Mr. Chairman and members of the committee. I'm Jim Monahan with the DuPont Group. I'm here specifically today on behalf of the New Hampshire nurse practitioners, but just for background for the committee, I've worked in these issues for some time. Back in, several years ago when House Bill 1623 was enacted, which really created the big launch of telehealth in New Hampshire, which took a lot of the provisions that were developed during the pandemic and put them into statute. So there was a standard of care for telehealth that marched on. And so in that space, I've worked with the nurse practitioners as well as the substance use providers, the mental health centers, and increasingly with the county governments, who's Dr. Ballard talked about. There's a really important waiver that the department has achieved, which would allow for care behind the walls for substance use disorder and other things as people are leaving. So I think the work that Senator Prentice has put into this bill is very timely, and obviously there would be a need to continue to work on it if you are open to amendments, which I was going to suggest. If you look at all the work that was done in updating statutes for telehealth, you'll find that the most common statutes that were amended would be 329, which is the physician insurgents. But pretty much everywhere where those statutes were updated for physicians and surgeons, we also updated RSA 326, which was the Nurse Practice Act, or for the nurse practitioners, because they are also prescribers under New Hampshire law. So I've talked to Senator Prentice and Dr. Ballard about this, that to be consistent with what we've always done, to include amendments to 326. I don't have those today, but I will prepare them. I should also say one of the earlier comments you heard from Dr. Ballard or Senator Prentice was the need for alignment between the state statutes and the federal guidelines, it's really can prove to be confusing and problematic not only for the providers but also for patients to knowing what the expectations are. And so I think wherever we can align, we should. One of the reasons I think that this bill is here is because there was an evolving position by the Drug Enforcement Agency around telehealth at the time House Bill 1623 was passed, which created this section. But as Dr. Ballard has indicated, that has evolved. And yeah, I think from my understanding from my clients that follow this nationally, there's very little interest in unringing that bill. The problem is it's hard to pass bills through the Congress. And so that's why they've done it through rules. Finally, let me address a couple of things that came up. I think, I'm not sure who it was, but somebody suggested that there should be some consideration to limiting this to non-opioids. I think we should be very careful about that. And I'm prepared to talk about it now, but really should talk with the SUD providers to see what the impact would be for them in this space, because I don't think we want, particularly in rural communities, I don't think we want to make an uninformed decision about that. It may be that they're fine with it, but I would check with them before we do it. And then finally, Senator President's reference physician's assistants. And I did notice on line 10 of the bill, physician assistants are covered because they are regulated under parts of RSA 329. I think that covers them completely, but I'm certainly happy to talk with their representatives to make sure that that's adequate.
That'd be great. And if you could get us that amendment to RSA 326 that you mentioned, we'd be happy to take a look at that.
Great, thank you.
Any questions?
Just, I thank you. Thank you, Jim Monahan. Chair Rushford, so I'm aware of that, the inclusion for the physician's assistants there, but I just want to be clear that we might have to point directly to, to their staff, make it clear. So I'm going to reach out to Dave Cuzzy and the president of the New Hampshire Physicians Assistant Association to find out what they would like to do. But I think we're going to do this be all inclusive. So thank
And that's
you,
who I was going
Jim,
to
for
reach out
bringing
to
this
as well.
up. Yeah.
So, okay, thank you.
Any other questions? No, thank you very much. Is there anyone else that has signed up to speak, or is anyone else like to speak that hasn't signed up? We'll have you check that list if you could.
Good morning.
Good morning.
For the record, I'm Erin Thorvaldson with the Council of State Government Justice Center
Okay.
here in support of SB 252. So like I said, I'm with the Council of State Government Justice Center. We are a national nonprofit, nonpartisan organization. We've worked in New Hampshire since 2021, studying and providing policy recommendations specific to those who are cycling between the behavioral health and criminal justice systems and who often have substance use disorders, mental health challenges, or both. SB 252 is a crucial step toward improving healthcare access for this vulnerable population. Our findings show that individuals releasing from prison overwhelmingly rely on Medicaid for behavioral health services, with 95% of Medicaid beneficiaries using Medicaid for SUD and mental health treatment between FY 2014 and FY 2023, at a 3-year cost of $46 million. Many experience housing instability, with 1 in 3 being unhoused at Medicaid enrollment, which further complicates their ability to access consistent medical care. Expanding telemedicine services, specifically for medication-assisted treatment and other essential healthcare services, will provide a necessary bridge to individuals facing barriers upon release. One of the most critical applications of this bill is the expansion of telemedicine for prescribing non-opioid and opioid-controlled substances. In February 2024, the New Hampshire Department of Corrections reported that 32% of incarcerated individuals were receiving medications for opioid use disorder. And that 80% of people with opioid use disorder were on such medications. However, access to these medications and other critical prescriptions often become disrupted upon release, increasing the risk of relapse, overdose, and justice system involvement. Best practice has shown that post-release access to these medications are essential for reducing overdose deaths and improving long-term recovery outcomes. As noted earlier, while New Hampshire's Medicaid reentry waiver covers many aspects of providing medications, the establishment of care, such as connecting individuals to community-based providers, remains a challenge. SB 252 would help address this gap by allowing telemedicine to facilitate pre-release case planning and post-release medical continuity, ensuring that individuals do not lose access to life-saving treatments due to logistical barriers. As Senator Prentice noted, SB 252 supports a broader continuum of care that is essential for reducing reliance on emergency services. Our findings found that individuals post-release frequently use ER services with SUD-related conditions, mental health crises, and opioid-related overdoses among the top reasons for first-time emergency department visits. Telemedicine plays a crucial role in reducing these costly and preventable hospital visits by providing timely access to care before medical conditions escalate. Our analysis further found that of those releasing who are Medicaid beneficiaries, 71% used Medicaid within 1 month of release, with a median of 9 days between release and their first Medicaid claim. This demonstrates an immediate and urgent need for medical services upon reentry, which could be more efficiently addressed through telemedicine-based consultations. In conclusion, Senate Bill 252 represents a critical advancement in ensuring that New Hampshire residents, specifically those facing systemic barriers to healthcare, can access essential medical services. By expanding telemedicine and requiring follow-up evaluations at proper times, SB 252 will help support improved health outcomes, reduce reliance on emergency services, and provide continuity of care for individuals with complex medical needs. I strongly urge you to support Senate Bill 252. I want to thank you for your time and consideration, and I will answer any questions you have.
Are there any questions? Thank you very much.
All right, thank you.
Any other speakers on Senate Bill 252? With that, I'll close the hearing. Give me that. I'll be right back. I'm introducing my bill here.
Okay. What's the number?
250.
So on your bill last night when I was at my fundraiser,
Okay, we're going to open up the hearing for SB 250 with the wonderful prime sponsors, and we're going to hear co-sponsors and a wonderful prime sponsor.
Thank you very much, Mr. Chairman. For the record, my name is David Rocher. I represent Senate District 1, which is all of Coos County in the northern third of Grafton County. And before you, you have Senate Bill 250, and just to point out that the title of the bill is a little more limited than what the bill does, and I think that was a change that happened during drafting with OLS. But what Senate Bill 250 will do, well, let's go back a little bit. In statute, pharmacists follow 2 chapters of law. One is Chapter 318, which is the Pharmacy Practice Act. And the other chapter in law is 318B, which is the Controlled Substance Act. In the 318, the law permits pharmacists to administer drugs. And we see this, we see it a lot of times with flu shots, other immunizations, other collaborative practice agreements with physicians where pharmacists are permitted to administer a variety of different types of drugs. When you look at 318B, the Controlled Substance Act, the part that defines what pharmacists can do is very close to 318, but it doesn't include the word administer. So the goal of this is two-pointed. One, to reduce ambiguity. When I brought this bill forward, there was some confusion even amongst my pharmacist peers that said, well, you can already do this. And I said, well, and the others said, no, we need this because it doesn't say it in the other section of law. So the goal here is to reduce ambiguity in what a pharmacist is permitted to do. But the greater goal in this, and the one that affects society at large, is the ability to allow pharmacists to administer controlled substances. So as we look at the work, we just talked about medication assisted treatments, substance abuse disorders, and it's become something that we've all been well versed in over the last several years. There are new therapies that have been developed that will allow patients to receive a once a month injection. Happens to be a controlled substance, and it will provide their medication assisted therapy for a month. And they don't have to go in to treatment centers. They don't have to go to pharmacies. And anytime that you can reduce the amount of times a drug is administered, you improve compliance and you improve outcomes. So in particularly, you think about, and we've heard testimony even in this committee, where there are taxi services, there are transportation services that have to, in some cases, daily drive patients to treatment facilities to get their medication assisted treatment. Well, so what happens if they can't get a ride, or the car breaks down, or there's a snowstorm, they go without therapy, and then what happens? Well, then they're put in a situation where they really shouldn't be or don't want to be. By permitting this action, permitting it by pharmacists, we can hopefully improve outcomes and reduce the amount of instances or risks of missing drug therapy. One of a couple of the things that we talk about as far as community pharmacists. Community pharmacists are really the frontline providers in the opioid use to fight against opioid use disorders. Only 55% of people with opioid use disorder receive any treatment, and only about 25% of those receiving treatment are able to access the medicated assisted therapy. So by allowing this treatment to be done in pharmacies, you're going to increase the amount of people that you can connect with and ultimately treat. And then I think I talked about this, and there's one thing in the bill that has to be addressed, but I can get to that in a minute. I was just up at Coos County Family Health on Monday, and we were talking about a variety of things that are going on in the state, and I mentioned this bill to them, and they said this would really help our community, and it would improve access to these types of drugs, and would allow treatment to occur on a wider scale. I did want to address one thing on the bill, and it's on page 3, lines 13 through 15. It has to do with payment. So we wanted to make sure, when I put this bill together, we wanted to make sure that pharmacists would be paid to do this. And obviously, pharmacists doing it is much different and probably more economical than an office visit, but we wanted to make sure there was access to payment there. I did speak to the Department of Insurance this morning, and they said that lines 13 through 15 should be worded differently to ensure that happens. They have offered an amendment that we can consider, but it's not a major. I think even if we want to do it as a committee amendment, that we could. But that's really the point of this bill. I would want to remind the committee that again, pharmacists are delivering these other drugs in community settings. Most importantly, we see vaccinations. It's estimated that since 2020, pharmacists have delivered over 1 billion vaccinations, injectables, in the last 5 years. So this practice is not new to them. It's not. It's something they're capable of doing, and it is an opportunity to utilize a skill that at this point is underutilized. So if there's any questions, I'd be happy to take them. Let me off easy. I'm going to get out of here before you think of something.
Thank you very much. No questions, seeing none. Michelle?
Good morning. My name is Michelle Heaton. I'm the Director of Life and Health with the New Hampshire Insurance Department. As Senator Rochfort said, The only concern we had was in those couple lines at the end, and we don't think after talking with Senator Rochert that really conveys what he was looking to do. So we have worked with him to come up with rewording of that, just to make clear that pharmacists are entitled to reimbursement when they administer the drugs, in addition to the reimbursement they receive for the actual drugs. So other than that, we don't have any issues with it, and happy to take any questions.
Mr. Chairman?
Any questions? Seeing none, thank you very much. Anyone else that would like to speak on Senate Bill 250? With that, I'll close the hearing. What, the amendment?
Yeah.
Yes, she just emailed it to me a minute ago. So if we had time, we could. Yeah. Okay, I'm going to open the hearing on Senate Bill 2.
Would you like?
Oh, this is mine.
Yeah.
This will be quick.
I'll grab the.
Oh, yeah, I got to give you the hammer.
Yeah, now it's official. I will open up the hearing on SB 254, and we'll hear from the prime sponsor.
Thank you, Mr. Chairman. For the record, my name is David Rochefort. I represent Senate District 1, which is all of the towns and unincorporated places of Coos County and the top third of Grafton County. This bill really, I look at the Senate Bill 254 relative to controlled substance inventories really as a technical correction. A number of years ago, the state of New Hampshire changed the controlled substance inventory laws that pharmacy has to abide by to align with federal law. And we just talked about that earlier this morning about aligning state law with federal law. The only problem is we got it right on line 5 where it lines it up with federal law. The only thing is we missed on line 6, we kept in a part of the old law, which says it has to be on every odd number year. That is not in line with federal law, and it's caused a lot of confusion and really, some burden for our regulators as well as pharmacies because the federal law is a little bit different than that. So that's all the bill does. Quick little technical correction. I hope that you would agree to pass this. So if there's any questions, I'd be happy to answer them.
Any questions from the committee? Seeing none. Thank you. Caitlin? We're just going to strike it.
Chairman Rochefort, members of the committee, my name is Caitlin Camo. I'm a resident of New Hampshire, a practicing pharmacist, and I also represent New Hampshire Pharmacists Association. I'm here to testify in support of Senate Bill 254. As Senator Rochefort mentioned, this is really just a technical change that allows a little bit more freedom for the pharmacies to conduct their business. I don't believe that it's really controversial in any way. It just allows us a little bit more flexibility to do the job that we do. And it aligns with federal statute and surrounding states. So happy to take any questions.
Are there any questions? Seeing none, thank you very much.
Thank you.
I'm going to close the hearing on Senate Bill. Is there anyone else who'd like to speak on 254? I know it's a high drama bill, but if not, we'll close the hearing on 254.
Geez, you're on a roll.
We're getting it. I know, this is my day. I put them all. Did this on purpose.
All right. You can do that too. So we're going to open up the hearing to SB 247. We're going to hear from the prime sponsor.
Thank you very much, Mr. Chairman. For the record, my name is David Rochefort. I represent Senate District 1. So probably take a little more time than the last one. The 247 deals with prohibiting network exclusion from pharmacies that refuse to dispense a prescription of the PBM reimbursement that is below the pharmacy's acquisition cost. So I'm happy to get deep in the weeds in this. And I'm willing to do that, but just as a 30,000 look at what this bill does. I know there are people that are going to speak behind me on this, but when a pharmacy fills a prescription, opens their doors, they accept insurance, if you will, but they don't contract most times directly with the insurance company. They contract with one of two types of intermediaries or middlemen. One is a pharmacy benefits manager, which I'm sure you've heard a lot about because there's been a lot of talk about that in the news. The other one is a PSAO, a Pharmacy Services Administration Organization, which is a middleman of the middleman. But at the end of the day, what this bill will do is it will provide some protections for pharmacies when reimbursements for drugs are below cost. As it is now, many plans, many contracts that we see state that a pharmacy has to fill all the prescriptions that are presented to them under a contract with their PBM provider, even if the reimbursement of that drug is below cost. So and if they don't do that, they run the risk of being excluded and kicked out of the network. So if they're filling 100 prescriptions in a day and 2 of them are below cost, or 3 of them, or 5 of them, or 10 of them are below cost, as the contracts state right now, they have to fill those at a loss or they're going to lose their network provisions. What this will do is it will allow them to, if a prescription comes out, the reimbursement comes out below cost, they have the ability to refuse that without affecting their network provisions. The other thing that this does is it starts to take a look at the Pharmacy Services Administration Organization. Like I said, these are the middlemen of the middlemen. The state and the state has over the years has done some work to regulate pharmacy benefit managers. Those are the traditional middlemen. But there really hasn't been much done to take a look at the the PSAOs, the Pharmacy Services Organization contractors. And I'm going to give you a story for myself. As you all know, I'm a pharmacist and owned pharmacies for many years and was very involved in the legislature prior to being elected to work hard to get protections from PBMs, and we did that, and it was successful, and in many cases hard fought, but we fought and we won, and we gained those protections. Well, probably 8 years ago, I was filling a prescription, and the reimbursement or the reimbursement levels, and I believe the audit specifications were in contrast with what the law said. So, and I knew what the law was. So I called the PBM and I said, "You're in violation of the law. We need to fix that." And they pointed me back to the PSAO that I was contracted with, and they were saying, "We're not violating law. They're violating the law." And I think a lot of times this PSAOs have become problematic, and this starts to begin to address that. This isn't wide sweeping reform by any means, but it just makes sure that the people that are responsible for making these decisions are the right ones that we're looking at. I have spoken with the Department of Insurance. There are a couple things that we need to change on this, something a little more than a committee amendment. One is the section of law that this is going into. There's a different section of law, so page 1, line 3, 402N is not the right section. So they're going to come back with an amendment to put that in the right section of law. And the other thing they brought out is the Department of Insurance does not look at these PSAO organizations. So they're going to come up with an amendment that puts that under consumer protection. So the pharmacies have protections afforded to them from the Department of Consumer Protections. But with that, I know we're all watching the clock. I'm gonna stop my testimony. I'm happy to answer a question, but I know there are pharmacists here that I believe will be testifying and can provide some more up-to-date information than what I can.
Any questions from the committee? Seeing none. Thank you,
Thank you.
Senator. Michelle?
Good. Michelle Heaton, Director of Life and Health for the New Hampshire Insurance Department. As Senator Rochefort said, we had some concerns with the placement of some of these provisions, and the way they're currently placed, it would make it difficult for us to implement the law. So we are working with Senator Rochefort to come up with an amendment that will address his concerns and put all the provisions in the appropriate spots to align better with his vision of what he wants to do. So happy to answer any questions.
Hopefully see those next week.
Yes.
All right. Thank you very much. Glenn?
Good morning.
You're good. Good morning.
Chair Rochefort, members of the committee. My name is Glenn Peralt. I am a pharmacist and an owner of Colonial Pharmacy in New London, New Hampshire. I've been a pharmacist since 1983. Have a lot of experience dealing with PBMs and contracting. This bill, as proposed, would definitely address a lot of concerns that I have with significant underwater reimbursement of brand name medications. I actively participated in the House PBM study committee that went on all summer long, testifying before them. Through my research of my own pharmacy over a 2-month period of time, my pharmacy lost over $6,000 in underwater reimbursement on brand name drugs. As a recourse, I've stopped stocking brand name drugs. My approach right now is that I will run the claim for the patient. If I get paid appropriately, I'll order the drug in for the patient. If I do not get paid appropriately, I will reach out to the PBM. I will ask the PBM where I can attain this drug for this price they're willing to pay me for. If I can do it, I'll order it in for the patient. Needless to say, there are a lot of patients that, while working with doctors, that we've had to switch off brand name drugs onto generic medications that are reimbursed, that are often their second or third choice of therapy. I have reached out personally to one PBM, CVS Caremark, over a concern with my contract. I don't know if you're familiar with the term redlining, but basically we strike out reimbursement parameters, write in a reimbursement parameter that will work for the pharmacy, that gives me an above board reimbursement, and present that back to the PBM. I got a call personally from the representative who negotiates for them, told me that it cannot be done. I believe divulged some information that he should not have divulged, but basically, in a nutshell, these different PBMs bid for contracts. And these contracts are awarded, of course, to the lowest bidder. Admitted to me that that CVS Caremark lost a significantly large contract to an underbid by a rival PBM, and that the rate offered to me will stand because they can't change this contract that they just won to this large national insurance provider. So this is unless there's something done, it's going to be a race to the bottom. I don't see any end to the negative reimbursements as these contract bids keep going lower and lower and lower and lower. I'm sure you have questions as to what my buying power is. So I purchase from one of the largest wholesalers in the country, Cardinal Drug. My buying group, the American Association of Pharmacists, is one of the largest buying groups in the country. That the number of stores that are represented by that buying group are about the size of a national chain such as Walgreens. We have buying power. I have a contract that allows me to purchase brand name medications for less than wholesale acquisition cost. I do not believe that the problem is on the buy side. And I guess that kind of closes out my statements. If there are any other questions, I'd be happy to entertain any questions.
Absolutely. Senator Ebard.
Thank you. So if I understand you correctly, the PBMs, they bid for the lowest contracts and then it goes to the lowest bidder. How does this affect your patient, or not your patients, but your customers? Are they getting the best drugs? Or are they getting...
So what's happening with the customers is I will try to deal with the PBM. The PBM is not willing to negotiate beyond what my contract states. I tell the patient, unfortunately, I can't obtain the drug for what I'm using the term insurance company, of course, is willing to pay for it. I cannot fill your prescription. And I'm willing to transfer that prescription to any pharmacy who's willing to fill it for you. After that, and of course, I've already reached out to the doctor and we've made clinical decisions, if there was a appropriate clinical change that we could make to a medication. So ultimately, most of the time, the patient is not getting that brand name drug from my pharmacy.
One dumb question?
Absolutely.
I'm a lot of dumb questions.
No dumb questions here.
All right. So your buying group is not the PBM. Your buying group is a group that buys at a wholesale or below market or below wholesale.
Correct.
How does the PSAO or the PBM get involved after you made a contract or you bought
So the
stuff?
The PSAO negotiates on my behalf, supposedly on my behalf, and accepts or declines a contract with a PBM who, bundles insurers into these particular plans and then sells and then negotiates that plan for this bundle of insurance companies. And from what my PSAO has told me, and I belong to 3 different PSAOs in my pharmacy ownership tenure, there's not a lot of back and forth. There is a take it or leave it from the PBM. If you don't want it, we will steer patients to a different pharmacy that will take it.
Follow up?
Yes. Is there a fee to be part of a PSAO?
There is. There is. I'd have to look and see what it is. It's an annual dues, but it's not a lot.
Okay, final one.
Yep.
Yeah, so what if we just got rid of the PSAOs and the PBMs? How would that help the customers?
I have discussed this amongst my peers, patients, physicians, many, many times. If you change the drug payment system to an EBT card, an HSA card, you allow the patient to make the decision where they want their medications filled. Patient says pharmacy down the road sells it for $10. Pharmacy up the road sells it for $12. I'm going to pharmacy down the road for $10. And they make their own healthcare decisions. If there's any rebate that's collected on a brand name medication because of a negotiation with an insurance company, they can decide what to do with that rebate money, whether it's returned and recharged on the patient's HSA card or whether they use it to pay down the patient's premium at the end of the year. It cuts out these multi-billion dollar Fortune 15 companies known as the PBMs who just suck up healthcare dollars, and it knocks them out of the equation.
All for lowering the cost, of course, for the consumer.
Correct. Because the consumer is their own best advocate. No consumer is going to shop at the most expensive retail or pharmacy outlet, whether it's mail order or your local pharmacy, community pharmacy, or a chain.
I'm all done.
All right. I've got a question for you on lines 11 through 15, Roman numeral 3. A pharmacy services administration organization contract with a pharmacy shall include a provision that requires the pharmacy services administration organization to provide to the contracted pharmacy a copy of any contract with a pharmacy benefit manager and amendments, payment schedules, reimbursement rates within 3 calendar days after the execution of a contract or an amendment to a contract signed on behalf of the independent pharmacy. I put that in there because I want to know that. You know, the PSAOs who are supposed to be working for the pharmacies, we're still not, you know, as pharmacists, so somebody's profiting off this. I mean, you hire them, you pay a fee to negotiate a good contract, and you're still getting a take it or leave it. So these operations are still doing business. You know, we talk about transparency. Wouldn't you like to know, you know, what kind of deal the PSAO is working on?
I would love to know that deal. Another thing, one thing to consider that makes it extremely difficult for either myself as a pharmacy owner who contracts directly with a plan, or with a PBM drug plan, or through a PSAO, is the contracts from PBM are very vague. For example, they will say things like the reimbursement rate will be MAC, which stands for maximum allowable cost, plus a dispensing fee of, generally it's somewhere between 25 cents and $1. What also came out this summer during our testimony before the PBM committee is these PBMs have 148 MAC lists. So if they say MAC, who the heck knows what MAC lists
So
are
for
going
the
on?
committee, MAC is maximum allowable cost. That's the maximum amount that they'll pay.
that they will pay.
Yeah.
Correct. There are 148 MAC lists, and depending on who the insurance company is and the number of lives they represent, they could assign a different MAC list within a particular PBM's plan, depending on how large the population is of the insurance company that they're dealing with. So I can't buy drugs based on how many lives an insurance company is taking care of. I have one price and one price only. So you can't keep track of the 148 MACs.
Great. Thank you. And I do want to make sure we're getting back in line with the bill. We're kind of where it's that can of worms. I don't want to go down there today.
No,
but, but Senator Avard has another question.
One more, yeah, and it's two-part. Basically, how many PSAOs are out there, and if lines 11 through 15, and we pass this bill and that is adopted, will this allow you to shop a PSAO a little better?
Yes and no. So there are, to my knowledge, off the top of my head, I know of 6 PSAOs. Generally, a PSAO is affiliated with a wholesaler, or there are 2 PSAOs that I know of that are independent PSAOs. But if for example, I'm a Cardinal store, so my PSAO is LeaderNet, which is affiliated through Cardinal. I can't take a contract, say, through Health Mart Atlas, which is a McKesson PSAO, because I'm not a McKesson client.
Thank you.
Yeah. Any other questions? Anyone else that'd like to speak on Senate Bill 247? Mr. Barry. Oh, there was another amendment. That's what you're talking to me about. Yes, I know it. Yep. Yes, yes. And actually, you can speak, but I can explain to the committee. So I got contacted by Medicaid the other day, and they were concerned because they're under federal guidelines. We can't change the federal guidelines, and we can't put Medicaid in jeopardy. So
Correct.
if I did not sum that up properly, you can do that.
That's essentially correct. And we were also worried about it conflicting with SB 119 as well. Which is the department requested bill about the generics. And
Oh yeah, exactly. Yes, yep, that's correct.
So that's it. Thank you. And for the record, Robert Berry, General Counsel, Division
Yep.
of Medicaid.
So we've got that amendment. So if we act on this, we'll make sure that that gets in there.
Thank you very much.
All right, thank you. Any further questions? With that, we'll close the hearing on Senate Bill 247. And we're not going to be executing today.
Oh, okay.
I mean, do we? So I have a motion to move into exec. Do I have a second? I have a second. All those in favor say aye.
Aye.
All right, we're in executive session.
I move SB 250 off the pass.
We had a motion and a second.
And
Okay.
there needs to be a committee amendment?
It needs to be a committee amendment. Sophie, do you have that?
Do it verbally.
Yeah, just read. It's a really quick line, I believe. And if you can read it, and if we want printed copies.
So it says, replace paragraph Roman numeral 7, I believe that is, with the following.
Right.
And then it says, yep, a pharmacist that administers drugs shall be reimbursed for administration services in addition to the reimbursement for the drug.
Got the nod, yes. So moved.
So we've got a motion on the amendment. We have a second. So all those in favor of the amendment say aye.
Aye.
Opposed? No
Move on to
opposed.
pass as amended.
Move on to pass as amended.
Second.
Is it a second? All those in favor say aye.
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 Any opposition? I got a motion from consent for Senator Byrd. So we're going too fast for you, Sophie. Let me know. Senator Avard seconds the motion to consent. All those in favor say aye.
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 Opposed? All right, I'll take that out.
Motion to move out of exec?
Second.
All those in favor say aye. All right, so if there's nothing else. We will.
Are you sure you want to say?
No, I know. Anything else?
We have to.
Slow it down now.
All right, I think we're good. We'll adjourn the hearing.
I can't remember.